I think we really need to work with politicians, but it's so difficult now because things are so partisan. Before, you could go and you could, you know, talk to your congressperson, no matter what party they were, and they could possibly be receptive. They may never agree with you, but they would be receptive. And you could have a civil conversation. Now we can't do that. So even the way to work politically has really interfered with our ability to get our point across. So I don't mean to sound pessimistic, because I'm not, because I still think that we can do this. And I'm hoping that this coming year that people are going to, it's finally going to smack them in the face. I think the Capitol riot have sort of smacked people in the face, because you can't make excuses for what's happening there. You can't excuse that behavior. You can't excuse the differences in the way Black Lives Matter protesters are treated when they march nonviolently, and then white supremacist rioters attack the Capitol. So those are sort of so disconnected that I think we can't ignore that happens. So because of that, I think that it gives us a little window, and I'm hoping that it gives us a little political capital to get our thoughts across, because more and more people are not thinking, I hope, partisanly, and will become more receptive to the arguments that support Medicare for all. And I don't want to keep talking because I can't, but that's kind of where I see the movement going. We have to become more political, and hopefully that we can get past this partisan divide and convince, not the population supports Medicare for all, but the Congress people aren't supporting the populations anymore. They're just supporting their party. It's not a policy issue. They're supporting their party, which makes the political route difficult.
Thank you, everyone, for inviting me to be with you all. I think one of the silver linings of having to be all virtual this year is that I'm getting to go to more meetings with people that I normally would not. So I try and keep that tiny little silver lining going. So I, as was mentioned in the intro, am currently a PhD student. And one of the reasons that I got involved with SNaHP and PNHP was because I'm doing biomedical research, and I'm seeing every day these new innovative treatments that are being discovered and pushed into clinical trials, often fully funded by the NIH, so taxpayers are funding them. And yet I know that when they leave the clinical trials, the patients who truly need them will not be able to afford them. And in my mind, that defeats the entire purpose of medical research. And so that, combined with my personal experiences as a type 1 diabetic in this country, which, as many of you who have had to interact with private insurance companies probably can guess, is a nightmare, kind of fueled my desire to get involved with the single payer movement. And I've been really lucky to be involved with not only SNaHP, but also the PNHP New York Metro chapter. And I've met some great mentors there over the past 5 years. And what I've really learned, and I've kind of been reflecting on lately, to think about what is the future of the single payer movement. So where do we go from here? Because the world is in turmoil, and how do we keep pushing for what we know should be a common sense policy, Medicare for all? And one point that I really want to talk about that I think Dr. Rogers laid out really well is our country has such an entrenched system of inequality that passing something like Medicare for all is going to take a massive re-centralization or alteration of our societal priorities. And that's not going to happen with a small movement. It's going to take a huge movement that is intersectional and also multi-issue. And that brings me to one of the things I've been focusing on in both SNaHP and at PNHP New York is coalition building. I think that is more important than ever. And when I say that, I mean coalition building between different healthcare professionals. Like was mentioned in my bio, I'm really passionate about including not only physicians, but dentists and nurses in the movement for Medicare for All, but also with other social justice movements. Because what I've learned over the past few years is that healthcare and lack of access to healthcare is intricately connected to the fight for a living minimum wage and our housing crisis. And all of us working in silos is not going to get us there. We really do need to work together. And I don't think that takes away from fighting for single payer. I think it only makes us stronger. And so in the same terms of that, I think we really need to grow the movement. And we hear that all the time, but exactly how we do it is kind of vague and really hard to get a grasp on. And so I think what we need to do is focus on healthcare professionals in our networks, because we are the most appropriate people to be talking to other physicians and other nurses and other healthcare providers about single payer and why we need it. And one thing that I think could be really helpful is if we got single payer more incorporated into the curriculums in med school. So I'm not a med student, but a lot of the SNaHP members I've talked to say that they get one lecture, if that, during their entire med school 4 years on health systems. And usually single payer is glossed over, and a lot of times it's given by a doctor who is either centrist or right-leaning. So you can imagine that single payer doesn't often get the best attention. So I think one initiative that could be really simple is if we have PNHP members who do work at teaching medical centers, we should try and have those people giving those lectures. So just small things like that to really introduce people to the movement as soon as they get in the medical profession, I think will be very helpful. Now, one thing I wanted to talk about and I was very excited about is that I know Minnesota has their own state single payer bill. And coming from New York, we also have a state single payer bill. And a lot of times the question comes up, well, is state single payer better than national and vice versa? And in my mind, I don't think it has to be an either or. And the reason I say that is because yes, they would be different, but when you're organizing around either, let's say, the Minnesota Health Plan or National Medicare for All, you're still talking to people about single payer healthcare. So you're still coming back to those points of healthcare is a human right. It would be funded by your ability to pay progressive payroll taxes. You could get medical care free at the point of service. So I think whether you're organizing, again, for state or national, we're still building the movement. And in my mind, either one that happens first, we can work with that. So if it's a national system that passes first and we get national Medicare for all, that is obviously the end goal that we want. If the conditions aren't right for a national system, but we are able to pass a state single payer bill in Minnesota or California or New York or wherever, that's a step forward that we can work with. And then we can strategize around that and make sure that we turn that state into the model for why it should be national. And so I did want to address that because I know a lot of times there can be that question, and I don't think it should be a question. I think it just strengthens our movement that we have so many bills out there saying we need a single payer health system and we need it now. And the last thing I wanted to touch on that I see as really important to the future of the single payer movement is making sure that we stay in the conversation and stay at the table. And what I mean by that is with the new administration coming in, there are a lot of health policy ideas that are being floated around, and unfortunately, single payer is not on the top of that list. So what we need to do as single payer advocates is keep it at the top of that list. And so in recent years, Medicare for All has come into the mainstream media. We need to work really hard to keep it there, to keep the pressure on our elected officials. but we also need to make sure that we're involved in all other health policy conversations. So there's a lot of health policy conversations about lowering drug prices. And I think that single payer advocates need to make sure our voices are heard in there so that these legislations aren't including things like copay caps, because a copay cap is not helping someone without insurance. So we need to make sure that there is a reduction in list price and that pharmaceutical companies are actually bringing down their prices. So that's just a small example of where I think our understanding of single payer health policy, but also wider health justice issues, is going to be really important in steering all of the health policy conversations that are happening in these next 4 years. Again, our ultimate goal is single payer, but we need to make sure that we are doing everything we can to get ourselves closer to single payer until we reach that final milestone. And I'll just leave on a note that I share Dr. Rogers' optimism. I think right now is such a crucial moment, and that's why I have been reflecting on how do we move the single payer movement forward. And I think, you know, statewide meetings like this and making sure that we're connecting with other advocates across the country is how we do it. So I'm very happy to be with y'all tonight to talk about how we win this.
I was blown away by those talks, of course, and both of them reminded me of a quote by a famous politician in Minnesota. His last name was Wellstone. His first name was Paul. Paul Wellstone always said, "We all do better when we all do better." And both of your talks emphasize that, and clearly that is very important for the movement of Medicare for all. And Rachel, I just wanted to say that we have just gotten into the first year medical school curriculum a 2.5 to 3 hour panel on healthcare, and I can assure you the panel will not be all right wing.
That's amazing, because I've heard from some students in New York that they don't paint single payer nicely. So I think that's exactly what we need to be doing.
Yeah, this will be a powerful panel, and it's going to be given to the first year medical school students in May, and it will be a part of the annual medical student curriculum. We also had 6 interns this last summer with us between the first and second year, working on different projects of PNHP. And actually one of them is at the meeting tonight and is on our board. So we have been a little bit influential, I think, in getting some of them very involved in this.
Great, great.
Good. Thank you so much, Dr. Rogers and Rachel. Question coming in from the audience. I know this is something we often talk about in Minnesota, and we have a number of really wonderful organizations, from the Minnesota Nurses Association to Healthcare for All Minnesota, working on single payer in Minnesota. And so we talk about sort of who engages what audience. And someone asked, does PNHP have a strategy for engaging with the general public?
Speaking locally is really important, and you will find a lot of groups in your community that do want to listen and possibly are working on the issue already, but you just didn't know that. For example, I've spoken to some patient advocacy organizations, and they focused on, which I mentioned before, drug pricing, but they hadn't really gotten an introduction to single payer. And so I got introduced to them and spoke to them, and you can kind of make those connections with groups that are already doing that work. So definitely looking locally. You don't have to search far and wide for groups that you can talk to. And a lot of it is similar messaging for when we talk to other healthcare professionals, just maybe a little less about how a physician's day-to-day would change, but more so for the patients. But it's a lot of the same points. So I'd really recommend speaking to the general public and just doing it locally.
Yeah, I think we all have so many connections, and I feel like the more personal stories I hear, it's always so powerful. I think everyone has a story about the negative interaction with the healthcare system, and it's getting everyone to kind of realize that we're all connected. I'd love to hear, as we move into a new national administration in 2 days, 3 days here, I'm looking forward in this really divided political time, what your thoughts are about effective kind of legislation and advocacy that we can be doing, if you have any ideas or strategies for working kind of both sides of the aisle.
So
go ahead, Rachel.
thank you. So I will start with kind of working, I guess, both sides of the aisle, but more with the public and not with legislators. I think what's really important, and Barrett, you mentioned this a little bit, is storytelling, and also just making sure that we're meeting people where they are. And so you may not want to go into an area that you know has a lot of people that may not be for single payer and start directly pressuring about Medicare for all single payer. What I find helpful is, and sometimes we've even used a survey as a tool to talk to people about their experiences with the healthcare system. And if you are talking to a more conservative leaning audience, you will find that after discussing their personal experiences and maybe having a conversation about some of your shared experiences, as you mentioned, no one likes their health insurance company. No one enjoys calling their health insurance company. It's really just getting through all of the myths that are out there about single payer and the partisan tales that they're told from the news and from the members of Congress who are against Medicare for all, and really just talking on a personal level. And so my advice again would be do it locally, but also invest in storytelling, because it's super powerful. And we've actually had people who go into the survey and they're like, healthcare is fine, it's whatever. And then they take it and they're like, wow, I never really wrote down and understood how much I've suffered because of this for-profit health system. And it helps people to understand why we're fighting for Medicare for all, rather than going in and, waving your finger at them and saying you need to support single payer. So I think that's one way that we can get bipartisan support. And it probably is never going to be 100% bipartisan support. In organizing, there's always that circle down there that you're not going to get to support it. But I do think there's a lot of people who have been hurt by the for-profit health system that we need to meet individually on a deep organizing level to talk about it. And I think that is where we start.
Yeah, I think there's several large groups that have difficulty grasping, the single payer concept too. One of that is labor. And I was talking to Mike Dudzik, who is the head of the labor organizations and who's, and in supporting single payer. And I asked him, I said, why is it that labor is so wedded to private health insurance when they know that their job, for whatever reason, may not be there tomorrow? And we all know that the pandemic has really made it clear how fragile that relationship is between your employer linking you to health insurance. And people lose their jobs or change jobs, employers change insurance plans. So even in the best of times, that relationship was never really rooted deeply. It was always fragile. And he describes it as people have a loss aversion and they're content to stay with the devil they know versus the devil they don't know, even though there is no devil on the other side of single payer. So it's the devil you know versus no devil, I think is a better answer. But that's been a big problem, and that people don't understand the dysfunction of private health insurance. I mean, how can it be that in a pandemic, when hospitals are running out of beds, that doctors and nurses are being fired? I mean, that's a hard concept to understand if you don't understand the financing of healthcare. And that should let people kind of make something go off and say something's not making sense here. So what instead we do is we fiddle and make small changes or change this and that, like the public option. And that, unfortunately, is what the current administration is proposing, is adding the public option. And all that will do is add more complexity, make things more fragmented. And I like to use the analogy that we have a foundation that's crumbling. And by adding a public house option, you're just adding more and more people into a house that's going to crumble. And you're not fixing anything. The public option it's not anywhere, none of its goals is universal coverage. None of its goals is to eliminate medical bankruptcy. So it may cover more people. And then we have to remember that coverage does not equal care, because of high deductibles and copays, that you may not be able to pay into the system enough to get your insurance active. So there's all of these areas. People just really need to be educated, but I think we really do need to work on this current administration that is not for single payer, even though I'm Becerra, who is supposedly, he has said that he is for Medicare for all. So we will see. There's some possibilities there.
Susan, this is John Crossan again. We have just had introduced into our Minnesota legislature a bill that actually is primarily a public option bill. And I'd like to hear you and Rachel maybe expand a little bit more on what the problems are with public option, and what kind of a stand should we take either for or against this bill?
Should definitely be against. What the public option does is it's just another passive transfer of money from the government to private health insurance by subsidizing these policies. And all it does is it adds to the fragmentation. It adds to narrow networks that will limit access to care. It adds to inadequate coverage for a lot of things. So it doesn't solve the problem. It is not going to get everybody covered. That's not, it has no goal of doing that. And that's the biggest thing, is that we want everybody covered. And that will simplify everything, and the public option will not. And even though the argument is that it will help and more people will be covered, I'm not convinced that more people will actually be able to access care that they can afford the copays and deductibles to cover. And it is not going to get a single payer. So I think it's just a waste of time and a waste of money. But we can see why the private insurance company is for it, why hospital corporations, all of these medical industry corporations that are just, raking in a ton of money like it, because they're getting more and more money from the government, whether they provide care or not.
And I will just add, I think that is perfectly laid out points on the public option. But one thing I think is, and I mentioned this before, we need to make sure we're in the conversation, because the messaging around the public option, they have actually co-opted the Medicare for All messaging. So if you remember back in the presidential primaries, it was Medicare for all who want it, and people claiming that it would be universal coverage. So if we do get a public option and it does fail, if it's messaged as Medicare for all, that would be a huge step back for the movement, because people would say Medicare for all was tried and it failed. So I think we need to make sure that we are out there saying, this is not Medicare for all, this is why we're against it. But one other thing I do want to add is, in terms of staying in the conversation, I think that we should add our voices and always say, why not Medicare for all instead of a public option? But if a public option is inevitable, it needs to not include private insurance companies. So in my mind, the worst case scenario is a public option including private insurance companies for all the points that Dr. Rogers just so clearly explained. It will just add the complexity, and it's, in my mind, doomed to fail. Now, a public option that is run entirely by federal entities and does not include private insurance still is not good. It's still not what we want, but I don't think it will be as much of a step back for the Medicare for All movement than a public option with private entities. So again, we're always pushing for Medicare for All, but if a public option has to happen, we need to make sure that it's not going to blow up the Medicare for All movement by one, false messaging, and two, including private insurance companies. So that's all I'll add on that. And one thing I think we can contribute as PNHP is cost analysis of exactly why the public option is not a good idea, and especially why the public option with private insurance is not a good idea. And I know a lot of analysis has been done by PNHP members, and I think there can be more that we can do, because PNHP has been a respected policy analysis group, and we do have the ear of politicians and other leaders. So I think we should use that to make sure that we're, again, always moving toward Medicare for All and dealing with the public option in the least destructive way possible.
That's a good point, Rachel, about the mismessaging, is that they try to frame it in a way that it really isn't. And so it makes the real thing look bad. And I mean, that's a clever game, but it gets used a lot. Yeah.
So if it happens, everyone on this call better submit their letters to the editor and their op-ed saying the public option is not Medicare for All, because we will need to get that out there.
Yeah, and one of the things I worry about, even if a public option started out with just being public funds, private insurance ends up co-opting it, just like they have privatized Medicare and they have privatized Medicaid. Those are federal funds, but it's not all. Parts of it are still going through private insurance kind of, so they will find their way to get in there, even if it doesn't start out like that.
Even the VA is starting to be privatized.
Yeah, excellent questions and points. One last quick question before we move on to our breakout rooms from Max at Hennepin County Medical Center here. Should we be pushing our hospitals and hospital systems to publicly support Medicare for All? Do you know of any other public county hospitals that officially support Medicare for All?
I don't know. County hospitals are government run. So I don't know if I don't know. I know that the county hospital in Illinois in Chicago doesn't. I mean, I know that some people in leadership support Medicare for All, but they are still dependent, and they clearly know that a Medicare for All system, which is the way it used to be, would work much better than what it is now.
I think I have the same knowledge that Dr. Rogers does. So I've seen people in leadership in some public hospitals in New York City who are known to be pro single payer. I have not seen a medical center come out in support of it. And I have tried at my academic medical center and a couple others in New York City to at least have conversations with leadership about single payer, since they are on paper supposed to be nonprofit organizations, and we have met a lot of resistance in that. And so if we're talking about trying to get medical centers to support Medicare for All, I think that is useful, even if you don't achieve that, just to understand and expose the reasons why they're not supporting it, right? So my CEO of my medical center is one of the highest paid medical center CEOs in the entire country, making tens of millions of dollars. So of course he doesn't want to lose his profits, and that's just my own opinion. But I think that, you know, exposing why they don't want Medicare for All is useful if you cannot get people to support Medicare for All in the leadership.
Thank you so much, Dr. Rogers and Rachel, for sharing your thoughts about where we are and where we're headed in the movement. I'm going to move folks into breakout rooms so that you can meet maybe some new folks, see some old familiar faces. Would love for you guys to kind of reflect on what you've heard tonight. I'd also give you the task of brainstorming something that you'd like to see PNHP do here in Minnesota in the next year, and then see if you can commit to an action of either coming up with something to recruit a friend or to make a call to a legislator, or whatever feels right for you. And then make sure to appoint one person in your group. We'll come back in about 10 minutes and share some of our ideas and reflections on the evening so far. All right, welcome back everyone. Thanks for sticking with me through the Zoom era of breakout room whiplash. So if everyone has hopefully appointed one person to kind of share their thoughts, either an action that they came up with or a goal that they'd love to see PNHP Minnesota engage in the next year. Does someone from group 1 want to share? You can just unmute yourself.
I guess I could try to summarize. I don't know if we really—
Great, just 30 seconds, a minute, whatever feels right.
We kind of talked about, Carla's on an HCAM and talked about that she'd been interested in like where PNHP's stance was going to be regarding the whole public option thing. And she was happy to hear that we're not supporting it either. But then, you know, the discussion kind of went to, you know, are we going to all get kind of just cornered into that this year? And how, and then also, then how do we kind of try to, is there a way to, well, I don't know, like go from that to being able to help push our cause as well. Like if we wind up with that, to be able to show people how much better single payer would be from that. And then also they were talking about teacher unions and not supporting single payer and quite a bit of it. And then how do we kind of help reinforce to them that it would leave them with more room at the bargaining table if their health insurance didn't have to be part of that bargaining system, you know, if they didn't have to worry about that part of it, but it's not going to be retroactive, meaning that, you know, all the dealings that have been happening through time and stuff, it's not going to be retroactive, obviously. And so it's going to seem unfair somewhat, you know, to, you know, kind of that whole, but what helps everyone kind of a thing. That's basically, I think that's basically it. If anybody else from group 1 wants to say something else. I mentioned that we needed to come up with a different name too, which I think a lot of us saying Medicare for All just doesn't do it because Medicare has too many shortcomings and stuff. Single payer, I don't know, mouthful. National health system taken by Britain. I don't know, can we use it? But something different so it doesn't have the bad connotations kind of that people already have in their head. I think, you know, I think it's kind of like, it's not helping us sell our cause, but
Improved Medicare for all.
Right, yeah, exactly. So usually that's what I'll use when I'm talking to my patients, because I talk politics with my patients a lot, probably more than health partners would like, but and I'm like, yeah, it's really like an improved Medicare for all, because yes, I know Medicare doesn't cover your physical, and that's stupid. I don't know why. Anyway, but yes, it would be improved. It would be different. It would be dental. It would be long-term care. It would be all of those things. But
awesome. Yeah, I feel like a huge takeaway from tonight is how important messaging is. Group 2, it looks like Ann Jones. Maybe are you all queued up and ready to share real quickly?
Sure, and others, please speak. Jim Carlson was with us, and Dave and Rosanna Garibaldi. So what should PNHP do? Honestly, get in front of more people. And my thought too, and listening to Dr. Rogers as well, we very seldom see anyone from PNHP on. See, I'm a nonstop consumer of national news because I'm retired and I can have it on all the time. We need people who are with us on these shows, you know, being interviewed and speaking to our issue nonstop. We have got to counter some of the negative messaging around a system. I like national health plans. You know, when I sometimes say Medicare for all, but I alternate by saying we need a national health plan, just like we have a national pension plan, which is Social Security. We can message this pretty easily. And our other thing, Jim Carlson that says he always talks to his doctors and dentists, always have information with you to leave in their hands. We have business cards, we have handouts. You know, I have a folder. Men don't carry handbags, but I carry a handbag. I always have stuff with me that I can hand out and leave behind.
I can
Dave,
attest to that.
Dave, Rosanna, and Jim, anything?
Oh, I just said I can attest to that. The first time I met you, I came away with a business card and a handout. So it works.
Right.
Excellent, excellent. Just
Well, Ann,
three.
Jim?
yeah, you covered it well, and covered it very well. Good.
Oh,
And we just have to make sure that we get, you know, also we cover the objections that people have, because
yeah.
it's very difficult to bring up a conversation when they have one objection that is misleading or is misinformation. So we have to have something that covers those objections.
Excellent.
Yeah.
Group three. That was Dave Dvorak, Henry, Linda, one other person.
Well, I can just speak. We didn't get very far. It seemed like that 10 minutes went by in about 30 seconds. So, but what we did touch on is kind of a similar thing that both Ann and Raina mentioned about branding single payer. I know this is kind of a perennial question, yeah, and you know, Medicare for All has taken on so many different meanings that it doesn't represent, you know, it's been diluted by a lot of other ideas. Yeah, you almost feel like we need to hire a Madison Avenue marketing firm to come up with something sexy. I think for a while they were talking about One Care Minnesota. Are they still talking about One Care? Oh, no.
That's an insurance plan.
That's an insurance plan. Okay.
Yeah.
The insurance plan has taken all the good.
Governor Waltz, and it's really just a smoke. It's a disguised insurance plan, right, Jim?
So yeah, they took all the good names already, but and then we spent a little time talking about displaced insurance workers, which is I think the only legitimate concern that people raise about single payer, but of course there's provisions in most major plans to retrain those workers. Just one thought that occurred to me during the main session, when somebody raised the question about the public, the county hospitals and the public clinics, it's got me thinking. I mean, that's kind of a low-hanging fruit for us in terms of building momentum. I mean, you're gonna, I've spoken at HCMC's grand rounds. I've spoken at like the North Point Clinic, and these docs are naturally, docs and nurses and providers are naturally our allies. Most of their payment is from public payers to begin with, and so I don't know. It's just something to think about going forward. Maybe if we we need to put more effort towards getting more public support from the institutions that are going to most obviously benefit and that are probably just from a policy standpoint most aligned with what we're doing, rather than going after the Fairviews and Health Partners.
Yeah, great.
Anybody else from the group?
Max chiming in the chat. The HCMC needs a campaign. We can get it done. Up next, do we have group 4? Is that Brian? Dick, looks like maybe Max is in there. Joe and Nelson.
We didn't get especially far either, and but a lot of this similar conversation that Dave was talking about came up. And actually, by chance or by design, like 3 of us in the breakout group are actually working on getting a letter to Hennepin leadership asking for endorsement of single payer. Because as Max said, it should be low hanging fruit. It would probably be a smart financial decision for our hospital, and it just goes along with our mission. And I liked what one of our speakers tonight was talking about when she just said it's even if it's not successful, it's helpful to get people on the record as to why they oppose single payer. I don't know if anyone else in the group wants to share, but like I said, we didn't really have any like big take home points that I think came out. Nelson had some other perspectives about, because several of us work at Hennepin where it probably is more aligned with people's general philosophy and politics to go along with single payer versus, you know, where you work in central Minnesota.
Yeah, I think we talk about that a lot of how do we have flexible messaging, because I think it can align with all of us. Group 5 is Bruce, Elizabeth, John, Catherine, Wayne. Someone want to chime in?
I'll chime in. Much of what has already been said, we discussed. We did feel that we need a different name, a name that is not so controversial and brings up so much negative thoughts. And we also discussed to some extent that we needed some financial studies, some cost-benefit studies, even though there are several out there, but we need cost-benefit studies that can actually get into the public media. We have excellent studies that have been published in journals like Lancet, but I think most of the general population does not read Lancet. So I'll stop there unless anybody else wants to say anything.
John, could I say something? This is Henry Homburger in
Hi,
Rochester. Henry. Hi. You know, I think the kind of financial studies that are needed are not studies, frankly, that convince politicians, but they're studies that convince the public. In other words, what would it look like if you make $70,000 a year to your taxes, to your paycheck, et cetera, if there was a universal health care plan? What would it look like if you made $200,000 a year? Because everybody hears it's going to raise your taxes and they immediately run to the hills and abandon the concept thinking they're going to get screwed. And the fact of the matter is, A, they're not going to get screwed, and B, the average person is going to come out ahead. There may be a few very quite a few very high income people that will pay more in taxes, but we've got to get beyond the notion and raise the public's consciousness that it's not going to hurt the average American.
Mm-hmm.
Yeah, thanks, Hank. That's why I made the comments I did. It has to be something that gets out into the public literature or the public media.
That's great. That makes you think about having, patient-centered outcomes for studies. It's good for single payer too. Room 6, I believe we're on, is Diane, Harvey, Carrie, Mary, Paul.
This is Mary. Actually, we only had 2 people. It was myself and Carrie, and I'm afraid I dominated the conversation. With one of the comments that I put in the chat earlier, I'm on Medicare, and one of my big crusades has been trying to convince people to trust Medicare, original Medicare, and not choose an Advantage plan, which is the private plan. And anyone who wants to talk, like on the primary season when this was all the rage, talking about a single payer plan, people don't seem to realize that our public plans, as Dr. Rogers pointed out, have already been integrated or invaded, however you want to put it, by private insurers, both Medicare and Medicaid. So, just saying Medicare for all, and when people complain about it, in many cases, I think they probably have the Advantage plans, which bring in all of the paraphernalia that goes with a private plan. Original Medicare is beautiful. It's practically paperless and worry-free. Now, of course, it doesn't cover dental and all of the auxiliary type of things, but I think, and I'm seeing Anne now on my screen, I think we would have to come up with a new name, because unfortunately, Medicare for All has been adulterated, basically, is the word I would use, by the private insurers. So if we're going to sell a single payer plan, I think maybe National Health Plan is good, although people who don't like the British plan, which is not just insurance, but actual providers also. So we don't want to become, we don't want to make it sound like we're coming that close to that particular plan. But it's so frustrating to me because I wasn't even able to talk my sister out of the going for an Advantage plan because people are afraid to let go, as Dr. Rogers says, of the devil they know for the devil they don't know, which isn't a devil at all, but it's, a good angel.
Yeah, that's so true.
That's the thing we're going to have to get over is people's fear, because as Senator Warren pointed out during those arguments, she said, I don't know anybody who loves their private plan, but people won't let it go. They take it right into Medicare.
Yeah. Thank you. I apologize for the time. I'm gonna groups 7, 8, 9, folks who haven't spoken yet. I feel like if anyone wants to pipe in any other ideas or thoughts that came up, or just even a thumbs up that
I was in 9, real quick. I think a couple of things. One, we ought to think about supporting deprivatization of the Minnesota Care and Medicaid. That's a step towards single payer. 2, I think we ought to take advantage of the fact that the Health Policy and Finance Chair in the House is a single payer supporter, and I'm pretty sure she's not getting barraged by PNHP people because I live with her. So I can tell you that she's not hearing a lot of single payer stuff, and even if COVID's going to sort of preempt 2021, you could get set up for 2022. So there's a target of opportunity. I don't know if Senator Wickland, I know Jim Carlson's on the call. I don't know if Senator Wickland's a single payer supporter. She's the ranking member of the DFL lead on the Senate side. So if we won the Senate in 2022, that would be a possibility. But I think those are the things we talked about. We also talked about a little bit about how the people get sort of misled by the plans we have now, which is similar to what other people.
Yeah, thank you. Great, and thank you so much to Dr. Rogers and to Rachel. Super appreciate you guys tuning in from across the country to our meeting. We're going to move into some more committee updates and kind of business. If everyone wants to give a virtual thumbs up, a wave, thank you all so much for joining our meeting tonight.
Thank you for asking me. I enjoy this too.
Thanks so much for having me. It was great.
Good night.
Thank you all.
Bye, everyone.
Bye.
Thank you so much. All right,
Barrett,
so
can I mention a good name? Can I mention a good name, Barrett?
Sorry, what?
Can I mention a good name for the insurance? Blue Zone. Blue Zone.
Oh yeah. Get us all into a blue zone. Yes, if we could all live and be so lucky. Excellent. Well, I'm gonna share my screen again here. And we're gonna move into just some committee updates from our committees that we have in PNHP. So the first committee, it's a new committee. I'm just going to give it a shout out. We are starting a more focused advocacy and outreach committee. It's something that as a board, as an organization, we are obviously committed to, but we're trying to make a more smaller focused working group. So at the end of this, we'll put in a link if you guys or anyone is interested in getting more involved in the committee. And then up next, we're going to hear from our Diversity, Equity, and Inclusion Committee, which I will share the slides for as well.
Thank you. It's very brief. No worries, everyone. This won't take long. But yeah, the Diversity, Equity, and Inclusion Committee really is just we're trying as an organization to be more intentional in in recognizing racism's role in healthcare and dedicating our efforts to be anti-racist. And so really our mission is to advocate for single-payer healthcare as a necessary step in addressing racial health inequities. And we'll approach this in several ways. Part of it will be partnering with communities, especially BIPOC communities, to learn about their barriers to care and kind of educate and advocate for universal healthcare and addressing those barriers. Also partnering with organizations that are also dedicated to anti-racism, and really just framing single payer from an anti-racist lens, and just making sure we're really communicating that language or that connection to the dysfunction of our health care system contributing to our current health disparities. And so basically we're welcoming general members to join this committee. There's several ways that general members can help. Really, the time commitment is flexible. We really just ask that people who join carry the values of anti-racism and cultural humility and really respect the time of our community members. We are developing kind of facilitator guides to help aid in the discussions that we will carry with community members and organizations. And how general members can help is really just helping us in finding community groups and organizations to reach out to, assist in developing a single payer advocacy guide with a racial equity focus. And then as we're developing these facilitator guides, we kind of have drafts of them, but we would love for general member feedback on those as well, just to make sure we're really communicating with our communities in respectful ways. And then lastly, I didn't mention yet, but we want to also increase the diversity of PNHP as an organization in our leadership and general membership. So general members can also help us in kind of expanding our reach in that way. So that's it.
Great, thank you so much. Apologize, I cut off your last slide there. So next up, we're going to hear just kind of a financial update from Dr. Elizabeth Frost, which I will slide over to her Treasury report.
Hi, everybody. My daughter just came home from ice skating, and I have my dog that joined me also in my room, so I apologize for any distractions. Hey, Alice, you need to go. Can you take Whisper, please? She just got home a second ago. Anyway, so this is a very brief overview of our finances over the past year, broken down into expenses and our income. And the expenses, you can see most of our expenses were personnel and people. That's about $54,000. And then we had rent, our accountant fees, technology, supplies and mailing, and miscellaneous, totaling about $67,000. And then for income, almost all of our income was donations. And we are very blessed to have a good donation base. We had 140 individual donors and 21 sustaining donors, and 70 donors gave $100 or less. And we really, really like the sustaining donors, so thank you so much. If anybody's thinking about becoming a sustaining donor, consider it. And then we're also happy to have some organizational donors. And then looking at the net income and growth, we had overall some net growth of about $8,000. So I would say we're stable financially, and I'm really grateful for all the donations. Thank you. And that's it.
Great, thank you so much. Next up, we are going to hear from the fundraising committee.
Hi, everyone. So as Dr. Frost was saying, thanks so much, Elizabeth, for that awesome update. We had quite a bit of costs. I know that she broke down the costs from 2020 a little bit, but I'll break it down a little further into what kind of impact we had. We had a ton of transition last year, of course, as the whole world did, and we, I think, pulled it off pretty well, but not without the efforts of all of our very generous donors. We had a single payer day on the Hill that just the week before transitioned from an in-person event to an online event. We transitioned pretty much everything we did to online. We had a ton of costs associated with that, administrative costs, costs of consultants, and then just our day-to-day costs, our rent that we pay for an office space with a mailbox, so that we can continue to just survive as a 501c3 nonprofit. All of those costs take a lot of money, so I'll touch quickly on what we did this past year as a fundraising group. Our biggest fundraising event last year was our gala in the spring. Thanks to everyone that has attended those in the past. Last year we brought in about $8,000 in that event. Coming up a little bit behind that was our letter writing campaign just at the end of the year. We raised about $6,500 in that letter writing campaign. It takes a lot of work to send about 2,000 letters to our awesome donors. So it's a big lift on volunteers with this group. And then about $1,000 were brought in between a few different activities, between Give to the Max Day. We had a 5K run, a virtual fun run on October 18th. And then I will just do a quick plug for our merch store, which brought in, it doesn't look like I can share, but I will just plug it real quick. We have a merch store that we launched. Oh, yes, there we go. It's at PNHP-Minnesota.threadless.com, and we can send it out in our next emailing. But we have a ton of great t-shirts, anything that you see in that. You can buy a button with a ton of different designs on it, a t-shirt, a bag, a mask. You can buy a face mask that has Medicare for All messaging on it. So those are some of the things that we have done to raise money last year. Thank you for linking the merch store, Jen. We have some big things coming up next year to continue to do what we do. We can't do what we do without all of this funding to support it. We have a plan to partner with a brewery to share funds for fundraising. So on a day, look out for this in our newsletter. There will be a day that you can go to a local brewery, and a percentage of any purchase that you make will come to us as an organization. And then our big lift will be a silent auction. We are also looking for general members to volunteer to make that silent auction happen, and just join our fundraising committee in general if you have other fundraising ideas for next year and future years, so that we as a nonprofit can continue to do this advocacy work. Just even staying open has quite a bit of cost involved, let alone planning those Day on the Hill events and other activities that cost funds. So we can absolutely use your help. Just email the PNHP email address if you're interested in joining our fundraising committee for this upcoming year. We will be talking about the silent auction planning and welcoming any new volunteers that are willing to join us on the first or second Saturday in February. So let us know if you are able to join. Thanks.
All right, thanks so much, Carrie. Dr. John Crossan, I think, is gonna say a quick word before we wrap up the meeting here.
Okay, I don't have too much to say. I just wanted to say that every time I go out of the house, I wear my Medicare for All mask, and it does get some good responses. And just to emphasize that our efforts next year will be to a large extent on advocacy, and we are going to require continued income to be able to do this. So we do appreciate everybody who has donated to us in the past and will donate to us in the future. So I'll turn it over to you, Barrett.
Great, thank you so much. Yeah, we absolutely are organization run on donations and appreciate all of you that have been active and donated time or financially. Thank you all so much for being here tonight. I know we ran a little bit over, but I know I feel energized hearing and seeing so many faces and hearing about ideas that you all have to forward this movement into 2021 and beyond. So just a reminder, if you are interested in getting more involved and are feeling ready to commit a little bit more time to PNHP, we have a link in the chat. You can sign up to be on our Advocacy and Outreach Committee, our Diversity and Equity Committee, or our Fundraising Committee. We are also putting out a call if anyone is interested in a larger commitment and becoming a board member. You're welcome to apply to join our board as well. And then finally, keep your eyes peeled. We try not to bombard you with too many emails these days, but we will hopefully be doing some legislative action this spring. It might be still brainstorming, but it might be through a letter writing campaign. And then we're really excited, we're going to be doing an implicit bias training coming up later this year as well. So if you're interested, keep watching your emails. Thank you all so much for being here tonight. Feel free to stick around if you have other questions or thoughts. Otherwise, have a good rest of your evening.